Good morning, afternoon, everyone. My name is Dr. Stephanie Lopez Neyman. I'm a nutritionist, registered dietitian, and equity health researcher whose work focuses on cardiovascular disease prevention, nutrition epidemiology, and community-based approaches to reducing chronic disease disparities. It is a pleasure to join you today to discuss how mobile health technologies can be leveraged to address cardiovascular health disparities through a multi-level strategy that considers individuals, communities, and policy environments. Over the past 2 decades, digital health technologies have transformed how healthcare can be delivered, monitored, and accessed. Among these innovations, mobile health, mHealth, has emerged as a promising tool for expanding access to care and supporting chronic disease prevention and management. Yet, technology alone does not guarantee better health outcomes for everyone. Before discussing potential solution, it is important to understand the problems these technologies are attempting to address. Despite remarkable advances in cardiovascular health prevention and treatment, the burden of cardiovascular disease remains unequally distributed across populations. This raises an important question. Who benefits from innovation? Who is left behind? Although cardiovascular disease remains the leading cause of morbidity and mortality in the United States, its burden is not shared equally across populations. As illustrated on this slide, the burden of cardiovascular disease is significantly greater among racial and ethnic minorities, particularly non-Hispanic Black, Hispanic populations compared with non-Hispanic white populations. While this presentation focused primarily on the United States, similarly, digital health equity challenges have been reported globally. Despite advances in cardiovascular prevention, treatment, and technology, disparities persist. This brings us to an important concept, health equity. The question is not whether we have solutions. The question is whether those solutions are reaching the populations who need them the most. To understand why these disparities persist, we must look beyond individual health behaviors and consider broader social and structural factors that influence cardiovascular health. Before discussing technology, it is important to understand the broader context in which cardiovascular health disparities occur. Cardiovascular health is influenced far more than individual factors. Factors such as lack of insurance, limited access to healthcare services, hazardous neighborhood environments, poor mental health, and underrepresentation research all contribute to unequal cardiovascular health outcomes. These factors rarely occur in isolation. Instead, they interact and accumulate over time, increasing the risk of cardiovascular disease and related comorbidities among racial and ethnic minorities. In other words, cardiovascular disparities are not simply the result of individual choices. They are influenced by social, economic, environmental, and healthcare-related factors that shape opportunities for health. Understanding these disparities provides important context for discussing one potential tool that has received increasing attention over the past several decades, mobile health or mHealth. The term mHealth may seem relatively new, but its development spans several decades. Early concepts emerged in the late 1990s under terms such as wireless telemedicine and mobile telemedicine. As mobile communication technologies evolved, so did the terminology, eventually leading to what we recognize as mobile health or mHealth. Although the terminology has changed over time, the central idea has remained remarkably consistent, using mobile communication technologies to support healthcare delivery and improve health outcomes. This evolution reminds us that mHealth is not a single technology or application. Rather, it represents part of a broader progression in digital health care innovation. To better understand where mHealth fits today, it is helpful to place it within the larger digital health ecosystem. Before discussing mHealth, Specifically, it is helpful to understand where it fits within the broader digital health landscape. Digital health is an umbrella term encompassing a broader range of technologies that support healthcare delivery, health promotion, and disease prevention. As shown here, digital health includes several overlapping information and communication technology or ICT domains, including telemedicine, telehealth, mHealth, electronic health, mHealth, mobile health, AI, artificial intelligence, big data, and omics technologies. mHealth is therefore one component of a much larger digital health ecosystem. What makes mHealth particularly important is its ability to reach individuals directly through mobile devices that many people already use in their daily lives. This creates opportunities to expand access to health information, support self-management, and engage patients in traditional healthcare settings. Because of this potential, researchers and healthcare providers have increasingly explored how mHealth can be used to improve cardiovascular health outcomes and reduce health disparities. So the question becomes, if mobile technologies can reach people where they live, work, and manage their health, how might they help address cardiovascular health disparities? Mobile health technologies hold significant potential for reducing cardiovascular health disparities among racial and ethnic minorities. The potential stems from three important advantages. Expand access beyond traditional healthcare settings. Enable continuous monitoring and timely intervention. Reduce transportation time and cost barriers. As illustrated on the right of this slide, the opportunity exists because smartphone ownership exceeds 80 to 90% across many racial and ethnic groups, beyond a platform for scalable cardiovascular health interventions. Several systematic reviews and comprehensive reviews have examined the role of mHealth technologies in cardiovascular disease prevention and management. Collectively, this literature suggests that mHealth intervention can improve access to care, medication adherence, self-management, and remote monitoring of cardiovascular risk factors. However, the literature also consistently identifies challenges related to digital literacy, device and broadband access, trust and privacy concerns, underrepresentation of diverse populations in digital health research. Together, these findings suggest that mHealth holds considerable promise, but its effectiveness depends on equitable implementation and inclusive design. Let's look more closely at what the evidence shows. On the left side of this slide, a recent systematic review and meta-analysis evaluated smartphone application-based interventions for cardiometabolic risk management across 74 studies involving more than 46,000 participants. At 6-month follow-up, smartphone-based interventions were associated with reductions in several important cardiometabolic risk factors, including body mass index, fasting plasma glucose, total cholesterol. These findings suggest that mobile technologies can support meaningful improvements in cardiovascular and metabolic health outcomes. On the right of this slide, beyond risk factor management, mHealth technologies have also demonstrated promise for improving medication adherence. A comprehensive review identified supporting use of text messaging interventions, mobile applications, and wearable devices to improve adherence among patients with chronic conditions such as diabetes and hypertension. Importantly, multifaceted approaches that combine strategies such as SMS reminders and teleconsultations appear especially promising, particularly in low-resource settings. Taken together, these findings demonstrate that mHealth interventions can improve a wide range of cardiovascular and cardiometabolic outcomes. However, An important question remains: if these interventions are effective, why do disparities persist? One important answer lies in what is commonly referred to as the digital divide. The digital divide refers to the gap between individuals who have adequate access to information and communication technologies and those who have limited or no access. A systematic review identified multiple factors that contributed to the digital divide, including socio-demographic characteristics, socioeconomic status, personal elements, for example, trust and risk perceptions, type of technology, and infrastructure. As illustrated on the right of this slide, what makes this issue particularly important is that access is not simply a matter of owning a device. As shown here, smartphone ownership is relatively high across income groups. However, differences become much more apparent when we look at broadband access. This suggests that access to technology exists on a spectrum rather than a simple yes or no conditions. In other words, having a smartphone does not necessarily mean an individual has reliable internet access, the digital skills needed to use health technologies, or the resources to fully engage with digital health interventions. These findings remind us that making technology available does not automatically guarantee benefits, and this brings us to a broader challenge that extends beyond technology itself. The challenge is not innovation, it's implementation. As we have seen, the technology exists. We have mobile applications, wearable devices, remote monitoring systems, and digital communication platforms. The evidence exists. Multiple reviews and studies have demonstrated improvements in cardiovascular risk factors, medication adherence, patient engagement, and access to care. Yet, despite these advances, cardiovascular health disparities remain. This suggests that technology innovation alone is not sufficient to achieve health equity. The question then becomes, how do we implement mHealth intervention in ways that are equitable, sustainable, and effective? In other words, how do we ensure that the populations most affected by cardiovascular disease are also the populations most likely to benefit from innovation? Answering that question requires us to move beyond technology itself and consider the broader systems in which these interventions are implemented. One useful way to think about this challenge is through a multi-level framework. To address disparities in digital health, we must consider the broader context in which people live and interact with technology. Imagine a patient living in a rural community with hypertension. She owns a smartphone, but broadband access is unreliable. Health information is difficult to understand, and digital tools are not culturally tailored to her needs. In that setting, the technology exists, but the benefit does not. This illustrates a central lesson from the digital health equity literature. Access alone is not enough. Digital health outcomes are shaped by policy, community relationships, individual capabilities, and the design of the intervention itself. Trust also matters. Communities are more likely to adopt and benefit from digital health tools when those tools are relevant, trustworthy, and developed with community input. Ultimately, technology works best when it complements trusted human relationships, including clinicians, community health workers, caregivers, and community organizations. One way to address the implementation gap is to apply a social-ecological lens to mHealth. This perspective recognizes that health behavior and health outcomes are influenced by multiple levels of the environment, not just individual choices. At the individual level, mHealth can support behavior change through tailored messaging and behavior tracking. However, individuals also need sufficient health literacy and digital literacy to effectively use these tools. At the personal level, family support and social networks can provide encouragement, accountability, and ongoing support that strengthens engagement with mHealth interventions. At the community level, trusted community partners and community health workers can help bridge gaps in access, trust, and cultural relevance. Community health workers are trusted members of the communities they serve who help connect individuals to health, information, healthcare services, and local resources. At the policy level, healthcare integration and broadband infrastructure can influence whether mHealth interventions are accessible and sustainable. The key message is that no single level is sufficient on its own. Sustainable and equitable implementation occurs when these levels work together. From an implementation science perspective, success depends not only on whether intervention works, but whether it fits within the real-world context where people live, work, seek care, and make health decisions. This raises an important question. What does a multi-level mHealth strategy look like in practice? Building on this framework, I will now discuss several practical strategies that can be implemented across these levels to promote more equitable adoption of mHealth technologies. Applying a multi-level approach is important, but implementation alone is not enough. The literature also suggests that certain characteristics consistently distinguish effective mHealth interventions from those that struggle to achieve meaningful impact. First, intervention should be culturally tailored. Messages, recommendations, and communication strategies should reflect the beliefs, values, and languages and lived experience of the populations they are intended to serve. Second, digital tools should be designed with health literacy in mind. Information should be understandable, actionable, and accessible to individuals with varying levels of health and digital literacy. Third, community partnerships are essential. Collaborating with trusted organizations and community leaders can improve relevance, engagement, and long-term sustainability. Finally, trust matters. Individuals are more likely to adopt and continue using mHealth technologies when they trust the information, the organizations delivering it, and the way their data are collected and protected. Effective mHealth interventions are not simply technology-driven. They are people-centered, community-informed, and equity-focused. Technology may deliver the intervention, but culture, literacy, community, and trust determine whether the intervention succeeds. Bringing these concepts together, we begin to envision a pathway toward more equitable and sustainable implementation of mHealth technologies. Looking ahead, future success will depend not only on technological innovation, but also on sustained investment in equitable implementation. From a research perspective, we need more equity-focused implementation studies, greater representation of diverse populations in digital health research, and longitudinal evaluations that examine long-term effectiveness and sustainability. From a practice perspective, integrating community health workers, adapting interventions for varying levels of health literacy, and strengthening community partnerships may improve adoption and engagement among underserved populations. From a policy perspective, expanding broadband access, investing in digital infrastructure, and developing sustainable reimbursement models, mechanisms by which healthcare providers, health systems, or organizations are paid for delivering services, may help reduce barriers to digital health utilization. If we want effective mHealth programs to last, we must ensure to support and reimburse these services over time. Ultimately, future innovations should be measured not only by technological advancement, but whether it reduces disparities and improves health equity. Future studies should therefore examine not only whether interventions improve outcomes, but whether they narrow existing gaps in cardiovascular health. As I conclude, I would like to leave you with 3 key take-home messages. First, closing the digital divide remains essential and means more than providing devices. It also means ensuring affordable broadband access, digital literacy support, culturally relevant tools, and equitable opportunities to benefit from innovation. Second, innovation must be aligned with equity. Effective mHealth interventions are culturally relevant, health literacy informed, community engaged, and built on trust. Third, implementation must occur across multiple levels. Sustainable change requires coordinated action at the individual, interpersonal, community, and policy levels. Ultimately, the future of mHealth should not be measured solely by technological advancements. It should be measured by whether innovation reaches the populations that need it most and contributes to reducing cardiovascular health disparities. The future of mHealth must be intentional, inclusive, and multi-level. Thank you for your time and attention. If there is one message I hope you take away today, it is this. The challenge is not innovation, it is implementation. We already have promising technologies. We already have growing evidence that mHealth can improve cardiovascular outcomes. The next step is ensuring these innovations are accessible, equitable, and implemented in ways that reach the population who need them the most. Thank you for your time and attention, and I would be happy to take any questions. If you would like to connect after today's session, the QR codes on this slide link to my professional website and LinkedIn profile.